Hello, welcome. My name is Lloyd Mobley. I practice in Castle Rock, Colorado, and have offices in Lone Tree and Castle Rock. I am with NeurosurgeryOne, and I am a neurosurgeon. I have been in practice for over 16 or 17 years in the Colorado region, and I trained in Omaha, Nebraska. If you're watching right now, you probably have low back pain or know somebody that does. You may know that the lifetime prevalence of low back pain in the general population is about 60 to 85%. So that means most people will get back pain sometime in their life. As a neurosurgeon, I do see patients with low back pain all of the time, and I see a lot of them. Most of the time, the low back pain will go away simply with time. However, sometimes people would need some kind of intervention to help them with their pain. I commonly prescribe a variety of conservative treatments for patients, including physical therapy, spinal injections, acupuncture, massage, chiropractic treatment, and a variety of other treatments that I call conservative treatments. A majority of patients do respond to these and can get on with their life with little or no back pain. But what if you continue to have low back pain? If you have low back pain that lasts more than 12 weeks, you have chronic low back pain. So what are your options? Well, surgery is usually the next option for most people after they have gone through the conservative treatments that I or others have prescribed. This could be any number of surgeries, including a laminectomy, a discectomy, or even a fusion, which many of you watching either have had one of these procedures or have been recommended to you. I do a lot of these procedures for my patients, and they are all very reasonable options for the right situations. But sometimes, and in your case, it may be the same way, it may not be for you. So if you don't want any of these options, what if you've already had surgery and you still have low back pain? If this sounds like this applies to you, keep listening. There's a new procedure called the Intracept Procedure. This targets a specific type of pain called vertebrogenic pain. Now, the vertebra is a vertebral body, which is the bone in your back. This procedure can help a large number of patients that have chronic low back pain. And it can help them have less pain and sometimes have no pain at all in a lot of circumstances. And the best thing is, if you are a good candidate, you can look forward to having a high success with this procedure and a pain relief that is long-lasting. So let's take a step back now and talk about low back pain and where low back pain comes from. Number one, muscle or ligament strain. This is probably one of the more common types of back pain, and it is often treatable by over-the-counter medications. Anti-inflammatories is what we call them, or NSAIDs, like ibuprofen or Aleve or any other number ones on the market. Sometimes rest, physical therapy, other types of therapies, and time. Another source of pain is the intervertebral disc, which is people just generally call it the disc. And we call it the intervertebral disc because it's between the two bones in your body. The discs can bulge, they can herniate, they can degenerate and get arthritic, or at least cause arthritis in the joints in the back of the spine. They can push on the nerves, and they can cause nerve pain as well, which you will feel as a pain that goes down your leg to the foot. They can degenerate. They can cause axial low back pain. And axial means straight up the middle of the back, so your low back hurts. This type of pain often requires further treatments beyond those utilized seen with muscle and ligament strain. These include injections and sometimes surgery. Another source of pain is the arthritis pain. And I will point this out on the slide here. Arthritis pain is pain that you'll see in the joints themselves, which is in the back of the spine, near the nerves, and sometimes the joints can grow and push on the nerves as well. So you can have a disc pushing on the nerve and the joint pushing on the nerve, and you can have back pain from the joint as well. And sometimes the muscles will react by getting inflamed and tighten up, and you can have muscle pain as well. So it's kind of a feedback loop which gets worse. So arthritis is certainly a problem. Osteoporosis. You have basically you can have a weak back where the bone gets weaker, and as you age, you are more prone to that bone breaking. Sometimes with little or no cause. You can bend over or sneeze, and if you have a weak enough bone, it can break. It can be very painful. These are easily treatable with something called a kyphoplasty, which I certainly will probably go into in further detail in a future live stream, but you can look up kyphoplasty if you have a vertebral fracture, which is painful. There are certainly other reasons for pain, but those are the main ones. So now that you understand where back pain usually comes from, I'm going to share with you the newest scientific findings that is kind of giving us an understanding of where another type of low back pain comes from, or at least some of the other types of back pain that we thought we understood better. It actually comes from in a certain percentage of patients. I'm going to circle back to the disc. Remember when I told you that there can be pain that comes from a disc? When I was in neurosurgical training, there used to be a procedure called IDT, which is the Intradiscal Electrothermal Therapy. And we thought a lot of pain came from the disc itself. And so the disc degenerates, and we can have an interventional doctor put a needle in, inject it with dye, and tell us, yes, there's pain when you inject a pressurized dye into a disc space. And so we thought that the disc was causing pain. So we would stick a needle, and we'll go to the thing here, and the doctor, which was also a pain doctor or an interventionalist, would stick a needle in the disc, and the needle would end up right there, and then he or she would put a catheter inside the disc and loop it around, and then he would heat up that whole length of catheter, and they would try to burn the pain fibers in the disc. The problem is it didn't work very well. The IDT results, and we'll go back to the slide here, they did a couple of studies which were powerful studies. They did prospective studies where they went forward. They treated some people with IDT, some people with nothing. And in one of the studies, placebo is actually, let me define that term. A placebo is a treatment that someone thinks they're getting a real treatment. They don't know they're getting a treatment or not, and they actually don't get one at all. And so the best studies will give you a treatment which is defined in the study that we're trying to study, or the treatment that we're trying to study, and the placebo, which is basically a sham where the patient thinks they don't know what they're getting. And so half the people will get the treatment, half will not, and then that way we can objectively look at who really got better. And then the people that look at the results, they're blinded by the actual treatment, so they don't know who got what treatment. They're just tabulating how well the patient did. And so what that does is it pretty much makes everything so objective, and then the results speak for themselves. And in this case, the results did speak for themselves, and they didn't do very well. The IDT procedure, VAS improvement, which is the visual analog score, only improved by 1.3 points, and we will understand that later when I talk about the Intracept. The ODI improvement only improved by 7, and in another study they really didn't go up at all. So the IDT was abandoned. I don't know, they may still be doing it, but it's not paid for by insurance companies for the most part, and because people didn't do that well, they moved on. So let's move on, and I'm going to talk to you about the science behind the Intracept procedure. So the reason why people didn't get better with the IDT is because it turns out the pain is actually coming from the bone itself, which is right next to the disc. So if you pressurize the disc, there are nerves inside of the bone that go right up to the disc, like roots that go down from a tree trunk, and they go down to the disc, both up and down in the bone. And that is called the basovertebral nerve. So we found out it was actually coming from the bone. So those tendrils, they go up to the bone, and they're just a normal part of our lives. We all have them, but when the disc degenerates and starts to go bad, the signals actually start ramping up. So that is called vertebrogenic pain. And if you haven't heard of vertebrogenic pain, don't worry about it. A lot of doctors haven't, and I'm out trying to educate various doctors, chiropractors, physical therapists, and other providers to help them understand what we're now understanding to be actually the cause of a lot of people's pain. Most times, all of the treatments I've discussed so far don't work, and you may be stuck in chronic pain, oftentimes leading to chronic opioid use, which are narcotics or pain pills as you know them, and you've probably heard in the news. It is a problem, and opioids are not the best treatment. Actually, they're probably one of the worst treatments for chronic pain, but that's sometimes the best people can do, and they try to get by with that. There are a lot of side effects, and so we need to get past that. So how do you know if you have vertebrogenic pain? Well, in this study in this treatment that they've studied extensively now, they've found that people that have modic changes, and we'll go to the slide here again. Modic changes is something that you probably don't know you have, and you may not even have it in the report on your MRI. A doctor like myself or a radiologist has to look at it and detect that there are modic changes. And basically, when the disc degenerates, the bone around it can change colors, and it can be quite distinctive or very, very subtle. And I'm used to picking up the subtleties, and I can tell if people have modic changes. You can have type 1 modic changes, which I won't get into the high details here, but there are 2 types of modic changes. The good news is, no matter which type of modic change you have, you are a good candidate, and people basically got the same relief from this treatment. And then another part of the good news is that if you have vertebrogenic pain, the procedure I'm about to discuss has a very good chance of reducing your pain. Intracept is an outpatient, minimally invasive procedure that targets the basovertebral nerve. And remember, that's the nerve that goes into the back of the bone and goes up and down towards the discs. It may also be called BVN, which is the basovertebral nerve. And this is responsible for the vertebrogenic pain that we're talking about. So the procedure itself is done with the patient comfortably asleep. I make a small cut in your skin, and then I place a metal needle. It's a large needle, but you're asleep and you don't get to see it. And I push it right into the bone. I just kind of tap it in, and I use 2 different x-rays machines to know that I'm going exactly where I need to go, which is basically dead center inside of the bone. And at that point, I will put a catheter out right next to basically right in the middle of the BVN, or that basovertebral nerve. And that probe has a tip on it that can heat up. And we call that an ablation or radiofrequency treatment. And that is heated for 15 minutes while you're asleep. And we're watching you carefully and taking good care of you. And sometimes putting another needle in while it's heating up, because if you may have more than one vertebral body that is affected. And so each vertebral body ablation takes about 15 minutes. So it could take anywhere between 15 to 45 minutes or so, depending on how many levels you have. After the procedure, and with very little recovery time afterwards, you get to go home and pretty much resume normal activity the next day. Now we, of course, because you had general anesthetic, we will have you take it easy and not do too much, but that should be it. Sometimes it can take a little while for it to kick in, and as I show you the results, you'll kind of see how over time the results actually improve incrementally, even up to a 5-year mark. So how well does this procedure work? We talked about the IDT, and we know it didn't work very well. So this procedure itself looks at the same 2 markers of pain that are very common in pain studies. One is the VAS. Now, the VAS is the visual analog scale, or the visual analog score, and it's basically if you've been in to see a doctor, they'll ask you, what is your pain between 0 and 10? They'll say 0 is no pain and 10 is the worst pain you've ever had. Now, some people, you may be included, come in and say it's a 15, and which is not possible in that scale, but as a doctor, I understand that when you say that, that means you're done with the pain. It's you know, psychologically just damaged you so much that you know, you want to get across that you're having so much pain. But the score, the scale itself goes from 0 to 10, and as you can see, I'll show you on the slide here. You may see it. You may have seen it with happy faces and sad faces, but a score of 0 out of 10 is a very happy face. Nobody wants to be in pain, and you're happier when you're not in pain, all the way up to the scale of 10. Now, the ODI score is called the Oswestry Disability Index, and it is a questionnaire that you may have filled out in the past. And all the studies that we do typically use this because it's very powerful in determining what kind of disability you have. They'll ask you questions like, how well do you do these tasks? You know, does it get in the way of this in your life? And there's 10 questions with 5 points each. And so we score them. The higher the number, the worse pain you have, or the worse it affects you functionally in your life. And so if you have 10 questions with 5 points each, the highest possible point score is 50, and then we do a modified ODI, which we double it, so it's easier to look at as a percentage. And so if you have 50 points, that's the worst you can get. You have a 100% modified ODI score. And so going back to the slide, you have 0 to 20 is minimal disability. So if you have 0 pain or up to 20, it really doesn't affect you that much. 21 to 40 is moderate, 41 to 60 is severe, 61 to 80 is crippling pain, basically impinges on all aspects of your life, and 81 to 100, basically most people in that scale are bedbound or exaggerating their symptoms, and you know, I have to assume, unless otherwise noted, that people aren't exaggerating their symptoms, but that these are real. If you're anywhere in the 60 plus or even 40 plus, you're certainly in a lot of pain. And so these studies, and the studies for the Intracept, uses the same measures, and here is what they found. The first study I'm going to kind of go over is the SMART trial, and you can Google it and look it up on the Intracept website. They enrolled 225 patients. They randomized them, meaning half of them or so got treatment, half of them did not. They did not know which treatment they received, and so it was blinded. And the results are the patients who were treated with Intracept did very well. After 3 months, their ODI score fell over 20 points. And so you'll see from the screen that the ODI score went from 42.4 down to 22.1. And that was at the 3-month mark. And if you march it out to 2 years, it continued to go down to 18.8. Now, this is not one individual patient. It's a conglomeration of the average of all the patients. That is a total of 54% reduction in the ODI. The VAS, which is the visual analog scale, was very similar. It went from 6.73 out of 10 down to a 3.8 out of 10 at the 3-month mark, and then it went down again to 3.13, which is a little bit lower at 2 years, which is a 53% decrease. So let's look at the longer term study. You know, is the pain going to come back? If you've had any procedure, you know if you have an injection, the pain's going to come back most of the time. That doesn't mean injections are not good. They're good at helping us figure out where the pain is coming from. Is there a specific area versus multiple areas? And sometimes people do get longer term pain relief. But with that, and as well as ablations of the facet joints, which is the arthritis I showed you before, oftentimes that pain comes back as well. So they did a longer term study with the SMART trial, and that was called the SMART 5-year trial. It showed even a more sustained pain relief. So with the ODI, now we're going back to the 24-month, which was 18.8 at the end of the other study. Going out 3 more years, it went down even more to 16.9. The visual analog score also went down. As you know, we finished at 3.13 at the end of 2 years. It continued to go down to a 2.35. So if you're living at a 6.73 on average, which is what all these patients were, if you put them all together, that is a big drop. That is a 65% decrease in your visual analog scale. Now, what that also means is that there were some people who had more pain at the end, but they may have started at a higher pain. This is just averages. On the flip side, that also means that some patients had maybe little or no pain. But comparative to 6.73, I think a 2.35 is definitely a decrease. And at 5 years, that definitely is a sustained result. So In terms of how well a procedure works, these results are, I think, quite amazing, and that's why I'm so excited about this treatment. The procedure is relatively quick. It's minimally invasive. You go home the same day. The results are good, and they do stand the test of time. So let's talk about what makes you eligible for the procedure. To be eligible for this procedure, you need to have the following 3 things. You need to have low back pain for more than 6 months. So that's beyond the chronic pain of 12 weeks. So you have to have low back pain for 6 months. And most people that come to see me fit that bill. So acute pain, meaning new pain, we don't jump to this treatment. We try the concerted treatment. So by the time you've had concerted treatments, you've usually had 6 months of pain. Number 2 is you have to have had treatment for that low back pain also for more than 6 months. And so if you've had number 2, then you've definitely had number 1, because if you had treatment for 6 months, then you've also had the pain for 6 months. So really number 2 and 3 are the ones we need to focus on. And then also modic changes on MRI. And that's what I was talking about earlier, those visual changes that I see in the bone on the MRI, which correlate with changes inside the bone physiologically in your body that make the basovertebral nerve grow more tendrils, that makes it more active, it makes the pain signals start firing that goes up to your brain. So if you don't know how to determine if you have these changes, which most people don't, or you haven't had an MRI, don't worry. I'm able to evaluate you and tell you if you are a good candidate for this procedure. So if you or somebody you know, a friend, family member, acquaintance, coworker, anybody, and they want to discuss this procedure and your back pain with me, call the number up on the screen, and that we'll put up at the end. And it's I'll verbally tell you, and so you can write it down now if you'd like. It's 720-797-7646, and it's option 5 to make an appointment with me. And just tell them that you heard this this talk today, and they will try to get you in as soon as possible. I have held open several clinic appointments over the next couple of weeks for today's viewers or for your friends and family. Anybody that calls in and says that they saw this Intracept presentation, just tell them you saw the Facebook stream and want to tell me and want to talk to me about Intracept and make an appointment. So we'll just leave it up to any questions you have, and I think some have already come in. And so I'll start with the first couple, and I'll read them out loud and answer them the best I can. So the first question is Intracept applicable and or preferred over RFA, which is radiofrequency ablation, and injections in the SI? I'm guessing that means SI joint. I'll talk about both, but I'm going to go with the assumption it's the SI joint. So I didn't talk about the SI joint, but the SI joint is very close to the lumbar spine and can be very difficult to tell the difference between the pain in the back and the pain in the SI joint. The SI joint, if you were to put your hand on your hips and kind of put your thumbs where the dimples are, that's kind of where the bone of the sacrum, which is the kind of the pizza-shaped bone at the bottom of the spine, meets with the iliac bones, which are your hip bones out here, and that hip bone, basically the iliac bones, and you can look that up, ILIAC, meets with the sacrum in 2 joints. There's one on each side, one this way and one this way. So the SI joint can cause a considerable amount of pain. And off topic, I do treat SI joint pain, both conservatively with, I send people for injections and RFAs. And there is a procedure that I do as well, another minimally invasive procedure that I put 2 little dowels inside the joint, and people get really good pain relief, and that's actually a great topic for another live stream. But the question is it preferred over those 2 treatments, the RFA and the injections of the SI joint? The Intracept cannot treat SI joint pain, unfortunately, because it is vertebrogenic inside the bone. It targets different nerves, but you may actually have both. You may have SI joint pain and modic changes, which would cause back pain, which is really close to the SI joint. So if you're getting good relief from an injection in the SI joint, then we can rule out vertebrogenic pain and focus on the SI joint pain, and I can also treat you for the SI joint pain. So those are great treatments for the SI joint. If you're talking about the S1 bone, which I don't think you are, the S1 bone can be treated with Intracept if it has modic changes. So that's first question. Thank you. That was a very good question. So is this procedure a good option for sciatic pain from piriformis syndrome? So I'll go into the background real quick of piriformis syndrome. So people that have sciatic pain or pain going down their leg often have pain coming from the disc pushing on the nerve, and that's called a radiculopathy. Sometimes people have sciatic pain, and sciatic is a catch-all term for any pain that kind of goes shooting down the back of the leg. And so we can't always tell if someone says, I have sciatic pain. I don't know if it's the nerve from the spine being, pinching on it, or if it's coming from somewhere along the length of the nerve, which is the actual sciatic nerve is a big bundle of different nerves besides the S1 nerve. And the point is the sciatic nerve goes through kind of a little notch area where the piriformis muscle, if it's tight, overly tight, it can push on the sciatic nerve and causes similar pain, which is not spinal in origin, but it is from the piriformis. Simple answer is no, it cannot treat that. Now, if you are having vertebrogenic back pain, which affects how you move and get around in life, and that affects how your piriformis reacts to that and can tighten up and make the sciatic pain worse, yes. And a lot of people will have a disc herniation, and that disc herniation will push on the S1 nerve, and they also have vertebrogenic back pain, and sometimes they also have piriformis syndrome. So there are a variety of things that we kind of have to work through. So if you're doing therapy for piriformis syndrome and maybe have had an injection in the piriformis muscle to kind of loosen it up and you get relief, then you focus on that. And unfortunately, Intracept cannot treat that, but it may treat a comorbid problem that you have, which could be vertebrogenic pain. Okay. I have tried PT and injections, but I am still suffering. What steps should I take to see if I'm a candidate for Intracept? So you've mentioned PT and injections, and those are the two things that I usually recommend. If you've not had an MRI, then you can either ask your primary care provider or whoever's kind of directing your treatment for an MRI. Alternatively, I do have a lot of people that come see me because they don't want to order the MRI, or it's more convenient, or you may not have to have a referral from your PCP. You can come see me because if you've had injections in PT, that means you've already kind of been in the system. I'm happy to see you and order the MRI. If you've had the MRI, unfortunately, if you read the report, you may not see modic changes, especially if they're subtle, notated on the actual report. So the best thing is to come see me. I will continue to look at conservative options for you because I'd say 20 to 25% of the people at the most end up having surgery at some point under my guidance. So, one thing that I'll mention is that just because you come see me doesn't mean that you will need surgery or that I'll recommend surgery. I am happy to talk to you about both options. And if it makes sense to have surgery, then yes. So the answer to your question is come see me. We'll order an MRI if you haven't had one. If you have had one, bring it with you, or at least let us know where you have had it, and we can upload it and take a look at it together. So this question is, I have a pinched nerve, and on my MRI, they found low back pain arthritis. They are both very painful, and all I have done are injections. Would this be a good treatment for me? I think I'll go back to the same, we'll go back to those three things. It sounds like you've probably had pain for at least 6 months and have had treatment for at least 6 months. So now we just need to find out, do you have modic changes? So this is a good kind of intro to go back to those three things. Don't know. Let's look at your MRI. What I can say is if you have modic changes, then we can address the back pain with the Intracept. One thing also that I did not mention is that generally it's accepted to under the L3, L4, and L5 and S1 bone and no higher. However, if any of those bones are affected and you have higher ones, we can try to work around that. So it is generally for the low back, L3, 4, 5, and S1. However, we can also talk about other treatments, potentially treatable with injections to find out how much pain is coming from the nerve being pinched versus the arthritis, because everyone gets arthritis, but not everybody has back pain from arthritis. So you may have a pinched nerve and leg pain and back pain, and the back pain may be from the vertebrogenic pain and not the arthritis, or it could be a combination of both. because the Intracept is such a minimally invasive procedure, what I am now recommending to patients is that they consider the Intracept to deal with their back pain. At least cut out that piece of the pie. So if your pain is a big piece of pie and half of your pain that's wrecking your life is coming from vertebrogenic back pain, if we can get rid of that, then we can kind of drill down on the other things. But there are a lot of other things that you probably haven't talked about with someone about your arthritis, about your pinched nerve. And like I said with the last question, you can come see me without any kind of pressure to do any treatment beyond just talking about it and getting educated. So I'm happy to do that. Can you review a patient's MRI without a patient coming into your clinic? We do not have a process by which you can do that as of right now. One thing you can do, if you have an MRI, start by looking at the report. If you don't see modic changes, which is MODIC, on the report anywhere, which a lot of times you won't, even if you have them, then you might be able to have somebody else tell you if you have them, but if they're not used to looking for them, then that may not be a good idea. I think the best way to see if you have them is to come see me. Now, from what I've seen, it's about 20 to 25% of people that have chronic low back pain and have not had treatment adequate for them will have some kind of modic changes. And so, there's a good chance you have it. It's not more than 50-50, which is not great. But, if you've lived with it this long, if there's a chance that we can get you feeling better, I think it's worth it to come in, take a look at the scans, and maybe I'll even uncover a treatment option that's not surgery that may have been not addressing up to this point. Next question is, I have low back pain. Should I come see a surgeon or a physiatrist to explore treatment? I think physiatrists are excellent physicians to kind of take people through and help diagnose sources of pain, help direct treatments, conservative treatments. As far as what I can recommend for conservative treatments and what they recommend are very similar. What they can do that I can't is that because they are physiatrists, they are well versed in how the body works kinetically, physiologically, how it moves, what kind of things that you can do with them or with physical therapy. And a lot of physiatrists actually are osteopaths, they're DOs, and they can do osteopathic manipulation and get you feeling better, which is can be basically kind of a first step in getting you feeling better. So I think if you're kind of in the beginning of your journey and have not had many conservative treatments, I think a physiatrist is excellent. You can see me, and oftentimes I will refer people to physiatrists. If you happen to have modic changes or haven't had an MRI and you get one, you have modic changes, then I think in my mind, most treatments are not going to treat vertebrogenic pain very well. So if you have modic changes and chronic back pain, I'm probably best suited to getting you the Intracept procedure and then trying other things if your pain doesn't go away. Is this procedure preferred at facets at L2 through 5 over RFA? So it all depends on where the pain is coming from. If you do not have modic changes, then basically we have to just kind of focus on the facet joints. So if you've had if you have facet arthritis and we think it's coming from the facet joints, which are the joints that I showed you on the arthritis slide, if you bend backwards, that will often aggravate the facet joint pain. If you've had injections and the pain goes away immediately, then comes back, we probably know you have facet joint pain, and therefore an RFA probably will help you if you've had responses to the injection at the facet joint. If you've had facet joint pain for a long time and maybe the treatments aren't working anymore, then it might be time to explore if you have modic changes and see if that is also what's going on, because you can certainly have both, because they kind of go hand in hand. As the disc degenerates, the joint spaces, the joint itself gets less competent, and you get facet arthritis along with it. So you can have both. But I certainly think they're two separate pain generators, and both are good treatments for each of those two pain generators. is this procedure commonly covered by insurance? I did not go over that on the slide, going through the slides, and I'm glad you asked that because this is a new procedure. It has been out for several years, but hasn't been used very much because it didn't have a code. Now they have given it a temporary code, which is kind of a like how a bill becomes a law. The cartoon from the 80s. I'm just a bill from Capitol Hill. This is the same thing. A procedure doesn't become a paid procedure until it goes through kind of a process of getting a temporary code, then a permanent code. Our best guess is that the permanent code is I think it's going to come out early next year. But with a temporary code, we are twisting the arms of insurance companies to approve these. If they approve the procedure after usually several letters from me, phone calls, the company itself helps with they have a doctor scientist that helps them send letters to the insurance companies until they say yes. And we're very, very aggressive and persistent, and that's where you have to have patience. Until we get a permanent code, it could take at least 45 days to several months to get it approved. Some people will opt to pay for it. It is, it's not as expensive as surgeries, but it's not cheap either. So, surgery centers cost money, doctors, anesthesiologists. So we really, really try hard to get it approved, but it can take some time. So if you've had chronic pain for a while, I think it's worth coming in, getting the authorization started, and at least we can start our process and work with the Intracept company to really twist our arms and get these companies used to the fact that this is a great procedure. People get great results, and even though they haven't seen this come across their desk, doesn't mean that they shouldn't approve it. So we're kind of in that phase of really having to fight hard for you. Hopefully it will be less next year. So right now, I think all insurance companies are saying no right off the bat, but we're working hard in educating them, and it's a process. But if it doesn't get approved, we won't have you do the procedure without you knowing it. We will be in touch with you every step of the way until we either get it approved or we have to decide to go a different direction. Do you offer telehealth appointments? We do. So yes, that's an easy question. I think those questions really kind of covered almost everything that we had. And any holes that I missed, certainly those questions did kind of hit some of the things that I didn't really get into. So thank you for joining us today. Thank you for joining me. I appreciate your time and spending it with me and learning about this Intracept procedure that I'm so excited about, and very excited about helping you, or at least exploring ways to help you. Even if it's not with Intracept, I look forward to meeting with you. Call the phone number that we will provide. Ask them to make an appointment with me. They will try to get you in as soon as possible. And like I said, we have open appointments, and we will get you in as soon as possible. Thank you.